A very good morning to everyone. I, Dr. Poonam Joshi, welcome you again in our Saturday ACTREC academic class. Today's presentation is by Dr. Akshat Malik, who is a consultant head and neck oncosurgeon at Max Institute of Cancer Care, Saket, New Delhi. He is a very close friend and a bright and would be taking the class on the mandibular involvement in oral cancer. So Dr. Akshat Malik, please go ahead with the presentation. Hello.
Sorry, I believe this is not playing. Give me 5 minutes. Tirtha, can you work it out, please?
Good morning, everyone. My name is Akshat Malik. I am a head and neck cancer surgeon at Max Saket, New Delhi. Today, I'll be speaking to you about mandibular involvement in oral cancers. We'll be covering this under the following headings. Initially, the applied anatomy. Good morning, everyone. My name is Akshat Malik. I am a head and neck cancer surgeon at Max Saket, New Delhi. Today, I'll be speaking to you about mandibular involvement in oral cancers. We'll be covering this under the following headings. Initially, the applied anatomy, routes of tumor entry, ways to assess bone erosion, types of mandibular resections, and classifications. Talking about applied anatomy, as you would all understand, mandible is important for airway stability, speech, deglutition, mastication, and shape of the lower face. Talking about the bony structures, as you can see out here, this is the ramus of the mandible. The ascending part is the ascent ramus. This is the condyle. This is the mandible notch or the sigmoid notch. This is the coronoid process. Here are the teeth and the occlusal surface. This is the mandibular foramen from where the mandibular nerve enters. It comes out from the mandibular foramen here and supplies this part. This is the oblique line. And inside we have got the mylohyoid line, which we'll be discussing in the next slide. The part in the midline is called the mental tubercle. If you look from inside, this is the mylohyoid, which I was talking about previously. This is the mandibular foramen, which we saw previous slide. This is also called pterygoid fovea, this part where lateral pterygoid attaches. Talking about muscular attachments, so this is temporalis muscle. It is coming and getting attached over the coronoid process. Here is the joint, capsule of the temporomandibular joint. This is the masseter muscle. It is starting from zygoma and it is getting attached over the angle of mandible. In the inner part, we have got the insertion of the pterygoid. So lateral pterygoid has got 2 insertions. They both come and attachments. They both come attached over the little pterygoid fovea. Medial pterygoid attaches over the inner aspect of the angle of mandible. And here you can see the attachment of the temporalis muscle over the coronoid. looking further into it, as you can see, this is the mylohyoid muscle. It is getting attached with the mylohyoid line. Regarding the midline structures, this is the hyoglossus muscle and the genioglossus muscle. These muscles, they attach in the inner aspect of the mid third of the mandible, right there in the mental of mentum. And when we do mid third mandibulectomy, of course, these muscles are cut, which are responsible for the tongue fall. Along with that, these are the other muscles which may be associated with mandible, or you should be aware of them. This is the digastric muscle. This is the stylohyoid muscle, the hyoglossus muscle, which we discussed, the mylohyoid muscle, which is going out there. And this is the antebelly of the digastric. Regarding the blood supply, mandible can have periosteal or endosteal blood supply. Arterial supply is through inferior artery, lingual artery, or facial artery, and venous supply is through the pterygoid venous plexus. Now, what happens when we talk about mandibular resections? Why we need to be aware of various classifications and why we need to discuss that we should be conserving mandible. So as you can make out, occlusion will definitely, as occlusion is being affected, so that is important because the patient will not be able to chew. The other thing will be speech. Because of inability to articulate properly, the patient's speech will be affected. The oral phase of swallowing will be impacted. There will be disruption of various masticatory muscles, so that will also cause swallowing problem because the jaw support will go, teeth will also go, patient will not be able to chew also. Oral competence is affected as the adjoining part of the lip or labial mucosa goes. There can be tongue fall when genial tubercle or genial complex is breached. Appearance is important. Appearance is affected in such cases as the bony support of the face goes away. And tongue mobility may also be impacted as the flap or whatever reconstruction we're doing may hinge on the tongue. Now, let's speak about how the tumor erodes onto the mandible. So there was this study by James Brown. This is a very landmark paper. I'm quite sure majority of you will be aware of this. So in a normal dentate mandible, the most common site of invasion into the mandible is the point of abutment. That is where the mucosa is reflected on to the mandible. So there's a normal mucosa. This is the point where it is getting reflected. This is called point of abutment. And this is the commonest site from where the tumor can enter. It can enter through Sharpney's fibers, which are present there. In edentulous mandible, the erosion can also happen from the occlusal surface. Besides that, there are several other ways of entry. If we start from one end, it can go in from mandibular foramen, coming on to the top from the attached gingiva, teeth, that is the occlusal surface. Then we like discussed previously the point of abutment or where the mucosa is being reflected. Then it can come from periodontal membrane, which is attached out here over the mandible, mental foramen, and even neck nodes can erode onto the mandible. Now, how do we decide which imaging do we prefer to find out about mandibular erosion? So there are several studies which have been conducted in this regard. Bottom line is OPG is of course inadequate. We require at least 30% bony erosion to see something on OPG clearly. Now talking about CT scan and MRI, there are also studies on cone beam CT and other types of CT. So definitely CT is more specific. MRI is more sensitive. If you are confused and you need problem solving, then you may probably end up requesting both these scans. Now, when we are talking about mandibular invasion, we also need to talk about paramandibular spread of the disease. So in such cases, disease may not be eroding onto the mandible. It may just be present next to the mandible. Now, why is this important? Because the third dimension, that is the base of the tumor, is formed by the mandible. Now, this can be assessed clinically. You can either try and move the tumor over the mandible? Are you able to lift it up, or is it fixed with the mandible? Secondly, what you can do is you can look at the scans to assess whether the disease is coming along. The other part would be looking at the scans for floor of mouth lesions, where you need to see whether the mylohyoid line is breached. You can look at the mylohyoid muscle. If it is going below the mylohyoid muscle, then probably you won't have enough stump of the mandible remaining to do a marginal mandibulectomy and still get proper base for the tumor. Now, talking about mandibular resections, they can be mucoperiostral stripping, though it's not mandibular resection, but we need to be aware of it. As tumors which are approaching mandible, in them many times we need to do mucoperiostral stripping. The other parts are marginal mandibulectomy and segmental mandibulectomy. Now, mucoperiostral stripping, like you can see in this patient, the growth is there in the buccal mucosa. It is coming close to the gingival sulcus. But if we just strip off this mucosa, we will be able to get at least 5 millimeter margins from the mandible. So adequate margins are possible without taking out the mandible. This should be avoided close of there is periosteal involvement, tissue involvement with marginal when disease or superficial bone erosion is present, and we are able to get a proper soft tissue clearance all around the tumor. Contraindications, of course, in gross bone erosion or gross paramandibular disease, relative contraindication would be radiotherapy and edentulous mandibles. Radiotherapy because periosteum is breached and tumor can enter from somewhere in between also. And edentulous mandible because many times the mandible may be pipe stem shaped and may not be thick enough. Now there are various types of these marginal mandibulectomies. You can do I would say conservative mandibular dissections. They are of various types. First is of course marginal mandibulectomy or a rim mandibulectomy, where we are taking out a rim or a margin of the mandible. So this was initially described for floor of mouth lesions, where wherever it is abutting, we take a soft tissue and we take the part of the mandible there. The character doing the marginal mandible. Maybe better to given an oblique provides assists us in getting an extra bit of margin or base for such tumors. For tumors in gingival sulcus, it may horizontal rather than floor of mouth lesion, as I showed in the previous slide. It needs to be more oblique so as to get proper soft tissue coverage. Now, along with marginal mandibulectomy, we can also have lingual plate resection, buccal plate resections, oblique, reverse marginal resections. So this is lingual plate resection. This is a floor of mouth lesion. Here, what we can do is we can go in with a saw directly. We can extract these teeth and put the saw in directly, and or we can even take drill and remove the lingual plate. That is the inner plate of the mandible. This may not be possible in all the cases, and it may be technically difficult to do at times. Buccal plate is just the opposite, where we are removing the buccal plate of the mandible and we are letting the lingual plate stay. Now, the risk with this is that the be strong enough to sustain the chewing forces and it may fracture. So generally just removing the buccal plate or the lingual plate is avoided. Now, oblique marginal, like I said, for floor of mouth lesions, we might consider that. For reverse marginal resections, if a node is there in the neck and it is invading onto the mandible or invading or having extensive soft tissue spread along the mandible, then you can probably do a reverse marginal resection. Now, marginal mandibulectomy per se can be horizontal or vertical. It may even be called as anterior, where it is just limited to the anterior part, or it may be lateral, where we're going through the ramus also. Posterior may involve the coronoid. Now, precautions which need to be kept out here are, number one, the angle which we are taking. It should not be sharp. We generally prefer taking a bow, the defect which is in a boat shaped manner, gently sloping. There should not be any sharp bulges there. Along with that, we should also be careful that we are having good soft tissue clearance. Other point to be aware of is, which is very important, that at least 1 centimeter stump of the mandible should be there. Otherwise, fracture of mandible can happen. Now, in edentulous mandible, like we discussed, the height of the mandible comes down. So there also we need to be able to save mandible. Coming on to segmental mandibulectomies, these are done when there's gross bone erosion, gross periosteal involvement or paramandibular disease. Relative indications would be prior radiotherapy or edentulous mandible. Segmental sections can be of various type. Posterior segmental means you are taking part of the horizontal part of the mandible, and as well as ascending rami as well as the condyle. Lateral segment would mean just removing this lateral part. We are not removing the condyle and other things. Now, if we are just removing the arch, the condyle, coronoid, the lateral part, but you are not removing the arch, the central arch, then it can be called arch preserving hemimandibulectomy. If you're going down till midline, then it can be called a hemimandibulectomy. If we are just removing the anterior part, it can be anterior segmental resection or mid-third segmental resection. Anything crossing midline and removing more than half of the mandible will be called extended hemimandibulectomy. Now, there are several classifications for this. Prominently known ones are by Dewar, Boyd, Erkin, Schultz, and Browns. So I'll just brush through these quickly. So Boyd's classification is also called the HCL classification, where the H is lateral defect of any length up to midline, including the condyle. So as you can see from these pictures, we're including the condyle and we're removing the lateral part of the mandible. So this is called H. C is anything in the central arch. L would mean lateral defects excluding the condyle. So depending on the defect, we label them according to what all is being removed. Along with that, for soft tissue involvement, there were some other nomenclatures which were added. O is no skin or mucosa. S is skin involvement. M is mucosa. SM is skin and mucosa, both are being removed. The next known classification is by Erkin. This was given 91. So he gave nomenclature of CRBS. C is, of course, the condyle. R is the rami. B is the body. S is the symphysis. So depending on how much we are removing, we may call it CR or CRB and so on. Schultz's classification was somewhat similar, that depending on whether condyle was going or not going and whether we are crossing midline and going on to the other side, he also classified this. The most recent classification was given by Browns, where he said that there were 4 pivot points. Now, these pivot points were the 2 angle of the mandibles and canines, the 2 canines. So depending on how many pivot points were going, accordingly, the classification was given. So class 1 would be only angle is going, 1C would be condyle. So any place where C is added means the condyle is also going. Class 2 would mean that 2 pivot points are going. So 1 angle and 1 canine. 3, both canine are going. 4 means canines as well as the angle. And 4C, of course, includes the condyle as well. Now, this is also very relevant classification. All these classifications, they help in deciding what sort of reconstruction we are looking at. So I'm not going into the reconstruction part right now, but this is important in planning it and also in discussing and explaining to other people how much we are removing. Thank you very much. I hope that this was beneficial to you all. Any questions, I'll be happy to answer. Thank you.
Yeah, thank you, Dr. Akshat. It was a very crisp
simple presentation, very description of very basics of mandible and their resection and the indication. The students to any questions. Hi, Akshat. Hello. Akshat, good morning. So shall I read the margins? The marrow is involved.
Yeah, definitely. Probably you can see when you are whether the marrow is bleeding. First of all, of course, it should, even if you are the disease is extending, you're rest when you are having adequate. Some people have sent, and then based on that needs to be done. So should I read the? You want to add on?
Yeah, yeah. So I think I would say is involved. Dr. Akshat said margins. I think the marrow is like a systemic involvement. Sometimes even you may end up still having a so really don't know when the marrow is involved what is a good margin. For like we say mucosal margins we take up to once. We for marrow there's no such we can go and we can go at to 1.5 centimeters. And if frozen, send the marrow for frozen, even the sensitivity of this marrow assessment on frozen is not great. So we have to go and take a wide margin. Hello.
Yeah, madam.
Yeah, Akshat, please go ahead. The other question is, what would be the ideal surgery for a lesion involving just the periosteum, the cortex, initially considered as a T3?
So it's not T3 lesion. No, staging where we are mentioning periosteum with regards to mandible. They can be, but size of become T3 or now it would depend whether tissue involvement margins you need to mandibulectomy is possible, but describing it to ask in such a think negative dissection may be possible.
Correct. I think, Dr. Saurabh Gupta, you want to?
Yeah. Hi, Dr. Chad. Yeah. Ask whether glossectomy, wherein either you have left the defect raw or you have somehow final report one positive or less than one. Would you advise that margins or would you advise?
So this or final histopathology?
No. Of surgery.
To revise the margin, if you can do that, the reconstruction, revision of margin, patient for chemoradiation.
Okay, and that is what that is why I said we no flap, nothing.
Yeah.
So the margin, I think yes, I know it is difficult for a repeat surgery. Patient may not understand, and sometimes we tend to follow chemo RT. So I think this message should be strongly conveyed that definitely a revision surgery has to be.
Definitely.
Thank you.
Any other questions?
Yeah.
So if there are no more questions, I would like to conclude today's class. Thank you, Akshat. I think there is one more question, I think. Akshat, can you
If
go
you're
ahead?
revising, yeah, ma'am.
Akshat, your voice is not clear.
Patient still needs CTRT.
Hello, Akshat, can you please?
Margins and I have revised it at the correct place, I would probably just consider RT in such cases.
Akshat, I think we
Hello,
could
can you hear me?
Akshat, we could not hear it properly. Can you?
Yeah, is it any better, madam? Hello.
Yeah, it is better now. Yeah. Hello.
Yeah. Madam, can you hear me?
Yeah, we can hear you,
All right.
Akshat.
Student of my margins later on, then probably
Hello.
Yeah.
Hello, Akshat. Yeah, Akshat. Can you please repeat the answer to that question? Because I think there was some issue with the net connectivity. If we are
Sure,
revising,
madam.
still
saying,
patient needs CTRT. Yeah.
I was saying if I am confident the revised margin, I know where to revise from and I'm sure that I've revised it properly, I would not consider CTRT. But then if there is some iota of doubt, I would probably give RT if this is the only indication, not CTRT. Because that is the very reason why we are revising and doing going ahead with proper margins. That is very essential.
Yes, correct. I also agree. So I think there's one more question, Akshat. Can you take it? There any time limit beyond which revision margin excision is not to be done?
So I would. So sorry, you want to answer it, madam?
No. Please go ahead.
Okay. So there is no time limit per se, but generally you would revise it if the patient comes to you within a couple of weeks time. If it's been more than 4 to 6 weeks, then there's no point in revising. You would rather observe or go ahead with whatever adjuvant is merited.
Yes. Yes, Akshat. So anything else anyone want to discuss with Dr. Akshat? So if there are no more questions, I would like to conclude today's class. I thank Dr. Akshat for taking a very good class for all of us. And I'm very sure we all learned a lot through this. So thank you, Akshat. We would like to have you again in our Saturday academic session on one of the Saturdays.
Thank you, madam. Thanks for the opportunity. Thank you.
Yeah, thank you, Akshat. Thank you.
अभी तो सर के बजाय कोई और आ जाए कोई आ जाएगा प्लान करेगा सर्जरी के साथ सर्जरी को पूरा हां कॉन्ट्रैक्टिंग वैसे किया है कंट्रीब्यूशन को हां दीवार वाली की कॉन्ट्रैक्ट वैसे किया वहां पे कुछ नहीं क्लास में सर्वे करे तो आएगा प्लान करेगा
कहाँ है?